my name is Sarita and I'm an OMS 2 on the Dublin campus. Today I'm going to be presenting my project, Visceral Involvement in Secondary Malignancy and Cutaneous T-cell Lymphoma, Clinical Characteristics and Outcomes. Cutaneous T-cell lymphoma is characterized by the proliferation of T-cells with a predilection for the skin. The incidence rate of CTCL is about 0.5 per 100,000, and the most common subtypes include mycosis fungoides and Sézary syndrome, which account for approximately 70% of cases, each exhibiting distinct clinical presentations and prognosis. Visceral involvement in cutaneous T-cell lymphoma is a rare phenomenon that may involve any organ. Despite its association with adverse outcomes, it is unexplored due to its limited occurrence. Visceral involvement in secondary malignancies and CTCL are rare and life-threatening, each presenting diagnostic and therapeutic challenges, but limited data exists on patient demographics, disease characteristics, and survival outcomes. The objective of this study was to assess clinical characteristics and outcomes of patients with and without visceral involvement of CTCL with the goal of identifying unique features associated with visceral disease. Moreover, we examined the prevalence and patient characteristics of CTCL patients with secondary solid tumor malignancies in hopes of finding correlating factors. We conducted a retrospective chart review of 650 patients diagnosed with mycosis fungoides or Sézary syndrome at Johns Hopkins between January 2011 and August 2024. There were 31 patients who exhibited visceral involvement in the cutaneous T-cell lymphoma, clinically classified according to the TNMB criteria, and determined by pathologic confirmation and/or clinical suspicion from imaging. 43 CTCL patients had confirmed secondary solid tumor malignancies after their CTCL diagnosis. There were also 2 patients in the visceral cohort who had also had a secondary solid tumor malignancy. Full clinical data was available for 270 CTCL patients without a history of visceral involvement or secondary solid tumor malignancy, and that was utilized as our control cohort. Exclusion criteria included bone marrow involvement and secondary solid tumor malignancies preceding their CTCL diagnosis. Some of the variables we collected included demographics, clinical features, treatment types, lab diagnostics, and imaging modalities. We also collected data on systemic treatments in the visceral and the secondary solid tumor malignancy cohort. Some highlights from our results section include the finding that the lung was the most common site for visceral involvement of CTCL in our cohort. In Figure 1, we have displayed all the locations of those in our cohort. We also analyzed the average time from CTCL diagnosis to visceral involvement as displayed in Figure 2. Visceral disease develops sooner after CTCL compared to secondary malignancy, with an average of 5.3 years versus 9.2 years for secondary malignancy. In our demographics analysis, we found all the information displayed in Table 1. Some highlights included male sex and advanced stage diagnosis and large cell transformations were all factors significantly associated with visceral involvement in CTCL, as opposed to secondary malignancy, which had higher rates in the white population with no significance in gender. We also examined systemic treatments for patients with visceral involvement as displayed in Table 2. It was found that bexarotene was the most used after visceral diagnosis, and patients used an average of around 4 systemic treatments after their visceral diagnosis. We also analyzed our survival analysis using a Kaplan-Meier curve. And visceral disease was associated with a shorter survival post-diagnosis, 1.6 years versus 5.6 years for those with secondary malignancy. In conclusion, our study found that although visceral involvement is a rare complication of CTCL, it has a significant effect on overall survival. Within the cohort of CTCL patients with visceral involvement, over 30% were initially diagnosed with early-stage CTCL. This is interesting because staging is one of the best indicators of prognosis, and an early stage often indicates a better patient outcome, which was not the case for those patients in our study. These factors differed from the secondary malignancy population, where early-stage CTCL was more common at diagnosis. Our findings caution us that patients with early-stage disease are still at risk for disease progression to visceral involvement, even 10+ years after the initial diagnosis. Close following with regular monitoring of constitutional symptoms, lymph node assessment, full physical exams, and prompt restaging at any signs concerning for disease progression should still be considered, even in early stage disease. Thank you for listening, and I wanted to give a special thanks to my mentor, Dr. Seema Rosati, and the MSTAR program for making this possible.